and nurse practitioners. Okay, so I'll give you guys a second online to look at this slide, but it's pretty much what I just went through, all about our unit. So then I want to talk a little bit about our daily routine. So we don't really have any automated screening. We have automated screening adjacent. So we get one big thing that we get are automatic OSI alerts. So anybody with an OSI over 10, because we do things like prospect, we have a lot of ARDS studies. I don't know if anybody does CDS. That's a pretty small one. And we did leopards. So that kind of tipped us off to the severe ARDS kids. And that comes through like our messaging system called Diagnotes. So I'm sure whatever messaging, HIPAA compliant messaging systems that you guys use, it's similar to that. But I'm hoping with Epic, we can get some pretty awesome automated screening. And I did hear some stuff about AI screening. I don't know if anybody's heard about it. I don't know much about it, but I don't know, maybe you should Google it. So all of our coordinators review for all of the studies daily. I know that that takes a little bit of extra time, but we kind of cut some corners in some other ways to make that possible. We do that so we can double check each other and make sure that we don't miss anyone. Our team has generally been a little more junior, so trying to get everybody trained, that's just kind of the way things have gone. So we screen for everybody screens for all of the studies in theory every day. We sort our list by newest admits to oldest admits. So obviously we screen the newest admits first. I'm sure you guys do that too. But we generally stop around the 7-day mark. That's kind of like our standard screening or more like express screening. And then if we look at the older admits, if we have time, like more in depth, but sometimes we don't have that luxury. So we kind of stop around the 7-day mark and just kind of skim the rest of them. If those kids have been there longer than 7 days, you're probably going to know their names or recognize them in some way. So that's one way that we cut corners to be able to get everybody to screen for every study. If a patient meets criteria, then we look at the notes. So we're not screening the clinical notes every day. We generally try to stick to the flow charts and get those like hard data screening. So like I said, with OSIs, those are actually in Cerner. So, we look at those when they were intubated, if they're on pressors in the MAR, those like hard data points, and we don't get into the nitty gritty of all of the words until we can tell that they can qualify from those hard data points. Another way that we make screening more efficient is we don't have that automated screening. And then this generally takes about depending on how express we're doing it, anywhere from like 15 to 45 minutes. So I'd say on average, maybe 30 minutes. And by 10 a.m., we're usually huddling. This allows us to double check each other, train staff, and really talk about what our day is going to look like and split up work amongst the team to make things easier. All right. So screening log wise, we have a Teams page, and we kind of adapted this Excel document from Nationwide. I did steal it. So here is where we normally keep the screening or the inclusion exclusion criteria for all of our studies at the top, and then some information on where to find like key study documents, whether that's a SharePoint, whether it's our like K drive, like the what do you call that? Like our document locations. Where to find the red cap, like if you need to randomize or something like that, or add the patient, and any other like contact information or any other important stuff that somebody that's filling in for you might need. And all of this houses every study that we have. So I just took this screenshot last week. So you can see all of our tabs at the bottom with all of our studies that we keep screening logs for. So that's kind of Riley's screening process. And now I think we're going to hear from Debbie at Penn State.
Good morning. As she said, I'm Debbie Spear. I'm from Penn State Children's Hospital. I am basically a one-person team, so my method, my way of doing things is probably very different than what most people do. But here's where we are. So our unit is a combined PICU and CVICU. It's 18-bed unit. And then our IMC is our overflow beds currently, with the plan that we are actually going to be taking over those 9 beds completely. We just have staffing issues to be able to man those beds currently. Because we just recently opened in the last few years a few more floors in the Children's Hospital. And while they were doing construction in the adult world, they actually were using one of our units. And since they moved back to the adult side, we moved our IMC to that unit. And so we are overtaking them, but we're still working on staffing. Over the last 3 years, we do have an average of 1,100 patients, which every year we keep breaking the record. Just the number of, we've been turning kids away. We do currently have 11 PICUs. We have, PICUs, 11 attendings. We have 2 fellows because unfortunately we did not match this past year. So I think next year they're going to take 2, be able to potentially take 2 to fill that. We do have 8 NPs or NPAs. Again, I am the only research coordinator currently with a 0.9 FTE, and part of my FTE is actually also devoted to BPS. And we actually use Cerner as well. There is talk that 6 to 7 years down the road, maybe going to Cerner, which is crazy because we just merged with another hospital, just joined our network, and they were epic, and they had to go and learn Cerner and to do all of that. I have no like automatic screening stuff whatsoever. I have no OI alerts. No, there's nothing. We have the very basic version of Cerner apparently that I can't set up any notifications. So basically what I do every day, I open our PICU list. I first do take a look at all the new admissions, looking at their H&Ps, narratives. If there is a narrative, nursing is kind of slacking those these days. And then I will go back and look at all the kids, the other kids in the unit, because again, we don't have anything in place. Our attendings are not necessarily the best of notifying me if there was a new line placed or someone was intubated, because we do near for kids. I pretty much have to look at everybody. I can't really cut off at 7 days because a lot of those kids that are there longer than 7 days might end up getting a new line or failed extubate, got re-intubated. So I kind of have to look at them all the time. And I do go look at our intermediate care unit lists because those are kids that sometimes they'll get, because we are a mixed unit over there now, if they're upgraded to PICU, they don't always come over if we don't, especially because we don't have beds, and they often kind of don't get alerted onto our screens as easily. I'm very old school, as one of my PIs said, but because of being a one-person show, I don't know if you can see that it's large enough, I actually carry a notebook that I have, again, all of the patients, the bed number, their MRN number, and initials. And then across the top, I usually just have like the basic studies that I need to pay the most attention to. And we have other studies that I might not need to do something with that I don't list on there. And then off to the right side, I just put like basic diagnosis things so that I can go back and refer to it if I need to. Once they're discharged, then I yellow it out to keep moving on. You can see there, like the kiddo second at the top, he, I don't remember at this point, obviously, was a precise, prospect, ships, CREET, and near for kids kiddo. So they qualified for all of them. Because of being a one-person show, sometimes we have to pick and choose a little bit and say, we can't do it all. Actually, I do know who this kiddo is now. And they were in precise, ships, and obviously then near for kids. And the clinical team actually would not allow us to put them in prospect because he was so very, very hemodynamically unstable, which was kind of a blessing because I'm like, I can't do this. Then I have again, because I'm old school, a little OCD, I do have an Excel sheet that I create usually on a Monday that and a lot, if the kids don't, are they still there? Obviously, I don't have to put their basic information, but I do. I have the basic information there. Once they're downgraded or whatever, I'll change to IMC, kind of keep a track of a little bit, just because sometimes I get mixed up in all that log and just to know what's going on. The biggest way that I have things done is I have a binder, because of being a one person and sometimes needing to tell my PIs, hey, you got to kind of help me out a little bit, but that my binder actually has all the screening logs for each study right in them. Section will have all the prospect stuff. I also keep in there precise, and when we were enrolling in Paradigm, the PRU screening log things. So anything that I might need to enroll somebody, basic study tidbit type things. Because when I do go away, I provide my attendings with, or my PIs. Neil my main PI calls it his enrollment for dummies. And it's basically step by step. And in the Word document part that I'll send them, it actually has like the link that they can just like click on it. So this is going to take you to RedCap. This is going to take you wherever. That section again has all the screening logs, the eligibility worksheets, just so that I know. And then should they meet criteria, need to go on a study ID log, that's in their section, and same with the consent log. Just because, again, being one person, I can't keep going back and forth to all my different binders or whatever. So once they're, I get a little stack of a few of them, then I will move them into the main study binder. But then it just makes it easier for me not to be lugging everything around all the time. I think that is it for mine. And next up, I think, is going to be Shelby from Stanford.
Hi, everyone. Oh, you can't hear me. Good morning. Okay, my name's Shelby. I'm from Stanford, also known as Lucille Packard Children's Hospital / Stanford Children's Hospital. It gets very confusing. Just to give you a general sense of our site, we are a split PICU CVICU. So we have 36 patients in our PICU with an additional 20 patients in our CVICU. We don't screen for all all studies in our CVICU, only a handful. So we do keep them separate. We use Epic, thank goodness. We have 2 screening personnel, 2 coordinators at our site, myself and Yossi. And we have about 14 studies right now that are actively screened daily. We have other studies that we don't screen for daily, but we can get into that in a little bit. We screen 5 days per week, 7 a.m. to 6 p.m. with usually about 2 screening points per day. And it takes about 45 to 60 minutes per person. And then we screen separately. So Yossi will screen for specific studies that are under her purview, and I screen for specific studies that are under my purview. So just like I said, we screen separately. This just works well for us. I trust Yossi, Yossi trusts me, and it tends to be more efficient for us. So pros, it's more focused. We're able to retain those inclusion/exclusion criteria. So we do a pretty good job of being able to kind of snapshot a new kiddo and know, do they qualify for our studies? Do they not? It is faster, right? Like if we're not double screening, it does make it more efficient. It's one person for our PIs to go to for their study. We have wonderful PI involvement. And so it's just nice for them to have kind of that go-to person for their study. If they like come across a kid and they're on service and they're like, I think this qualifies for this thing. It's just nice for them to kind of know who to go to. And we still see who approaches who, and we double check each other. So the screenshot is Yossi's like secure email she sends me daily, which I love. And it basically walks through the kid, This is for PAPO2, not a PALISI study, but it's one that she is in charge of. And it gives the kid the drug that they're on to see if they qualify, and then any reasoning why they do or don't qualify. And so it's kind of our good double checkpoint. So I know where she is, she knows where I am, and it's a good log for us. Cons for this system, there's less overlap of knowledge. So it does, if one of us is on vacation, there is some balance to be had of like having to absorb their screening. That's maybe not as intuitive or as routine for us to work on. And then there's potentially less likely to catch an oversight. So if I'm not actively looking for PAPO2 in a kiddo and they would qualify and Yossi like happens to miss it, 1 in 100 chance, you might not catch that oversight. So yeah. For screening tools, so we do screening spreadsheets for each study instead of one altogether. This works well for us in order to be able to send our screening logs for the studies that require it. And it just works well to give access to people who need it and access to people and don't give access to people who don't. It's kind of a Stanford PHI P2 requirement. So we do keep it separate. And then we do have a hospital privacy spreadsheet basically, which is an Epic Access spreadsheet that we have to update for specific studies, which is basically the date we access Epic for that kid, their MRN, their patient name, why we assessed it and who assessed it, and like what content was assessed. So that is another spreadsheet that we do utilize, which is nice if you're going back and there's any privacy issues or anything that comes up. That's a nice spreadsheet to have. Okay, so a little bit of tips and tricks. We are entering the automated world of Epic, which is so nice. So we do run spreadsheet or like run, whatever you call these, cohort thingy-mabobs. I'm sure our IT team is like yelling at me because they're like, these are complicated. But basically we have one for Paradigm, which gives us like, it's the top, and I included some factors that were for Prospect, just to make it easier on me, but includes different categories. So it'll show like when they're admitted, what department they're in, what ventilator type and mode they're on. So that implies like, oh, they're ventilated. Their HFOV, their FiO2 map, those are kind of more for Prospect. If they're on ECMO, because we all know if a kiddo goes on ECMO, it's kind of an all hands on deck. They qualify for like literally everything. Medications that they're on specifically, so it would be like pressors for Paradigm, their most recent bilirubin level, their most recent lactate level. Anyways, you can see it. So it's a nice snapshot for us in the morning to be able to start there. And then similar to Kirsten's team, we kind of use this as a snapshot. And then if we see there's maybe a sense that they would qualify, that's when we dive a bit deeper into their chart to confirm all of the rest of it works. Slicer Dicer is a nice tool for something like bacon to confirm that you captured, if you're in like their prevalence cohort, then make sure you capture every kiddo that came in. I don't know if you guys use patient lists in Epic, but I do, and it's a really great way to kind of plop kids into their buckets. And it gives you like, you can set it up, but it gives you like their name, MRN, so it's easy to go into the chart for data entry. It's, if they've been captured on your screening log, etc. And then one thing we've started doing recently that I love is we get CRRT and ECMO order notifications. So these go straight to your email and they pop in right when that order goes for the kid. We find that like CRRT, ECMO, those are two huge, like need to know now, need to start kind of moving forward with proceeding with enrollment potentially. And so those are really, really nice to have. And we've utilized those a lot. Our PIs are also on those usually. So oftentimes there's going to be like a 2-minute gap before I see my email and they get their notification and then I get a text and I'm like, I just saw it, give me a second. So pros and cons, but we do love that. And then this is also just kind of an efficiency tip. I've created a folder in my computer that's kind of a screening packet and it holds all of the Prolux criteria, the age or the ranges for blood pressure that are normal, so you know if it's gone outside of it. POPO2 drugs that we're specifically looking at that kind of picks case case control breakdown. Anything that I use on a routine basis to pull from when I'm screening, I keep in one folder. It's just kind of nice. I open it up and it's easy. I set reminders in my calendar to send screening logs because we all know like the month rolls around and we're like, oh crap, it's sorry, oh crap, it's September and I forgot to send the screening logs for that study. So it's just nice to have it reminded. And then I do bookmark everything. So like when I go in the morning, I'll pull up Epic, I'll pull up my screening packet, I'll pop up a bookmark. I always start with Nationwide since we all know how their login system gets a little temperamental. And yeah, and it's just kind of an easy, efficient, straightforward way to do things, I think. And then finally, utilizing your frontline providers. I think this is an under capitalized on thing to do. So our chief actually recommended this. And he said it's like basically they get a chance to win $1 million, which means they get a lottery ticket. And it basically encourages our fellows, APPs, and hospitalists to actively reach out to us if they have a kiddo that they think qualifies. And there's no harm, no foul to getting that call or that text that's like, I think this kid does. And then you go in and they're like, no, they don't. But it's a nice double check, extra step. They're on the floor. They know when things change. They know when that kid has been intubated before the system does. And so it's just a great thing to utilize. We've used it a lot, actually, especially for if anybody's in PI SCAP. That's critical to knowing when those kids are coming in or anything with a very tight timeline for enrollment. That's what we try to prioritize for our frontline providers. And that's it for me. Thanks. I think Sean's up next and virtual. Oh, yeah. Slicer Dicer is a system in Epic that it basically pulls, you can filter through diagnoses. Oh, sorry. Slicer Dicer is a system in Epic. It's like a tool. And you basically can filter by drug, by disease diagnosis, by age. So it's a great, it tends to be better utilized for those retrospective, more chart review studies. I don't think it's the best for active screening, but for Bacon, we use it a lot to ensure that we've captured everyone for our prevalence cohort. I check it every Friday to make sure that I've gotten everyone for the week. If we're not doing weekends, or I missed a Sunday because I was traveling or something. So yeah, that's a great tool. There's a lot of YouTube videos I've looked at a lot of them. Yeah. Yeah. That's a great question. It's newly implemented, so I don't know if we've seen it fully fledged to the best of its ability yet. But with PI SCAP, we've captured everyone, and it's based on this frontline provider involvement, and then rapid changes. So Prospect, we have kids who for lack of a better word, kind of tank, and we get notified right away by a provider that their OIs are increasing dramatically and they're thinking about an oscillator. And so then we come in, and it's a nice, I would say our notification, it would probably increase, we probably capture 5 more kids than we might. And the importance is kind of that window. So we get them before they've fallen back out. So if we see a kiddo who's been kind of intermittently on pressors and is intubated, and we're like, okay, this could be a paradigm kid. If we find them when they're on pressors, then I'll volt the nurse and be like, hey, can you let me know if this kid goes on pressors again or whatever? And so those kind of contacts have been really, really helpful.
All right, can everyone hear me?
Yes, we can.
Nice, thank you. So my name's Sean. I'm a research assistant from the Children's Hospital of Philadelphia, and I'm going to go through our screening process. So we have a 75-bed PICU, a 24-bed PCU that will screen for 19 of our studies twice daily. And then our morning screen takes roughly 90 minutes, depending on the amount of newly admitted patients that day. And then we also use Epic. Next slide. Thank you. So this is a screen grab of our Epic reports that we use for our screening. So I'll direct your attention in the bottom left corner, our PICU patient report, and then in the middle of the screen, the PICU vent report. These are the two main reports that we kind of use to pull all admitted kids and then all kids who have any vent needs in the PICU. And then we have some other study-specific reports that we'll use, as well as some that we'll use as hotspots for patients that will fully rescreen. And then I'll talk about some of these a little later. Next slide. So this is a screen grab of our daily patient sheet. So on the top left picture, we'll kind of track every patient who's admitted to the PICU on a given day with some demographic information. And we'll compare the previous day with the report that we pulled from Epic for the day that we're screening. What we'll do is we'll use an an Excel formula, kind of sort out those patients. And then once we sort them, at the bottom left is what we'll copy and paste into our screening notebook. And then on the right-hand side of this slide is kind of our event list. So on the left column is our main notebook, which is a event list that we're kind of tracking each day that we're screening. And we'll compare that with the Epic report that we pulled that morning to find out who's been either extubated, transferred out of the PICU, or has newly been intubated, or a new patient with any vent needs. And then we'll copy and paste this information into our Excel screening notebook. Next slide. Thank you. So our screening notebook is broken down into 3 different sections. This first section is all the kids who have been newly admitted or patients with new vent needs, and then any patient we may identify on a report that we're going to fully rescreen. It's broken down into a few different columns here. The first few are the demographic information we're pulling from Epic. We'll find some issues of why they're here, and then we have some access, and then antibiotics, culture sections, and then we broke it down into our organ dysfunction. So we're able to kind of clearly highlight anything that a patient might meet eligibility for, and then able to pull it all together at the end in our eligibility section. We have this set up so it kind of allows us to efficiently go through each patient when we report out in morning huddle. And then the way we'll kind of report these patients out to all the RCs on the team is through the tiers. So you'll see patients highlighted in green, which is kind of our top tier, has the most eligibility and highest priority of approach. Anyone highlighted in blue may be a study or two that they're eligible for, or a patient that meets a lot of our exclusion criteria. And then in yellow, any patient that may be worth following up later in the day or the next day for any potential study eligibility. Next slide. This second section of our screening notebook is our event list. This is updated twice daily, and it's a running list of all the patients in the PICU who are vented, and we'll follow these patients on this list for any of the ARDS studies they might be eligible for. And we'll highlight those that we're following, unhighlight anyone who may exclude, may have previously been enrolled, or anyone who has been enrolled. But this will reflect an accurate list of all the patients in EPIC who are vented. Next slide. Yes. Thank you. This last section here is our reports. So we have some in here for specific studies that will use all of those EPIC reports that you saw previously. And then we'll use some of those ones also to identify any patients who may have been admitted for a little bit that we want to rescreen again for any new study eligibility. These are also a running list and will reflect all the reports that you pull from Epic. So we'll keep these up to date, also twice daily. Anyone newly on these reports will highlight green. If they're on, for example, the vaso report or our cardiac arrest section, we'll put them all the way up top and fully rescreen them. And then anyone who may exclude, we might highlight in red and make sure that we don't need to continue going through them. A couple sections in here that are kind of team specific for us are the continued procedure section, the recap section, and then the study coverage one. So we use the procedures to kind of outline our day and then delegate any tasks for any study procedures that need to be completed. Our recap section we'll use in the afternoon, and then we'll recap any enrollments that happened that day, and then any outstanding procedures that might still need to be completed. And then everyone on our team is cross-trained in our studies. So if someone's out for the day, we'll have the study coverage there and who's covering to allow us to communicate with that person if there's anything in question for eligibility or any procedures that need to be completed still. And next slide. This is a screenshot of some of our, or two of our screening logs here. Top one being one of the more basic ones. And it's nice when we pull everything from Epic into our screening notebook, we're able to kind of just copy and paste the demographic information. And then with our organ dysfunction section in screening, able to have those dates and times for anything that we need to include in there. For our team, this is a research assistant responsibility. So it's nice we kind of set ourselves up in the morning for us to be able to easily go through and add all the patients necessary to the log. Next slide. Thank you. For the last slide here, a couple tools that our team kind of uses only for screening, but the first one on the left is our screening email that we'll send out after each time we screen. This will go to all the PIs, all the attendings, any other hospital personnel that are involved in some of our studies, other research teams that utilize our process to find eligible patients for their studies, and then any other team we may share an approach with. So this allows us to kind of keep everyone updated who's involved with anyone who's potentially eligible for our studies. And then at the top right, this is kind of a tool we use as a screening flow sheet for all of our studies. It'll have all your basic inclusion, exclusion criteria on there to determine eligibility. This is nice for any new research assistant that is learning to screen for a specific study, but also nice for whoever's kind of covering down on the study. You have everything you need. And then at the bottom is something we put together for some of our studies with similar MODS criteria. For the research assistants, we kind of have this in front of us. It has all the criteria in one place. It allows us to screen one patient for multiple studies a lot easier than flipping through a bunch of different flow sheets. But that's all I have, and any questions? Thank you.
All right, thanks to all of our speakers. I'm just going to go back to the first slide with everyone's pictures, and we can do questions if anyone has any. Anyone online? All right, I had a few. Debbie, I wanted to know for how long do you do you keep things in your like singular binder before you move them to like the study specific binders?
It all depends on honestly how thick it gets. Sometimes like I do like Shelby does, I have a alert set that for ones that I have the screening logs that I have to actually send in versus, prospect, I enter them every week or sometimes every couple days. I just kind of let them build up and then I'll move them over. It just depends. It's just so much easier to have them in one place. And I also don't like to move them too early and then not have a couple behind that might have had a screening number because especially if it's sequential. So I don't want to move it. I always want to at least keep the most recent one that qualified for something. I do have to say that sites that have their PIs that are very involved are lucky. I have to say, I mean, Neil is fantastic and but he doesn't do much clinical time. So it seems like my attendings that are on, they kind of look out for their own study and not necessarily each other's always. So I don't have the luxury of having somebody to say, hey, this kid might qualify. On occasion, one or two might, but for the most part, no. I have to be screening 7 days a week, twice a day. And it's hard for me to be away for that reason to, like for right now, honestly, if there's a Creek kiddo, they won't be enrolled this week because the PI is on clinical service. And so I'm not there. So those of you
Well-
with more than one coordinator are lucky.
Well, you should be proud of yourself for all that you do, and it's okay if you leave for vacation or something. Not every single kid that's eligible ends up getting enrolled. It's okay. But thanks, Debbie. Shelby, I wanted to ask you sort of, maybe sort of in line, but slightly tangential, and similar to Joe's question for your, when you get reached out to the people on service, do you have any, like, how does that communication flow work, especially like off hours or weekends? How do you sort of manage that?
Yeah. I think Yossi and I are really lucky that I think our teens really love us, which is a gift and a curse in a slight way, because we do get those like Saturday 10 p.m. phone calls, and I'm like, oh, okay, I guess I'm going to get this kid now. The communication flow mostly works with, like, we present that flyer at huddle, like our morning huddle for all of the APPs, hospitalists, attendings, anyone, so that they all are aware of our faces, know our names, and have our phone numbers. And then we have the like kind of just basic overview of what the studies do. And then they know to just volt us, which I don't know if that's a common like app for everyone. It's like our HIPAA compliant like text messaging service. It's like similar to Tiger Text, yeah. They know to volt message us or call us directly. And then we just talk through the kiddo that they think qualifies for whatever study at whatever time. Yeah, does that answer your question?
Do they tend to only do it during the day, or is it like sometimes the person overnight, you get an ice cap kid and they like vaulting you at 2 a.m.?
Yeah, I've definitely gotten phone calls very late, like at 2 and 3 and 4. When we're kind of presenting that worksheet, we really emphasize like PISCAP and prospect, just with like enrollment numbers, like the tighter enrollment timelines. Like we can't, if a PISCAP kiddo comes in at 1 a.m., by the time we screen at 7, like they don't qualify anymore because the enrollment window is gone. So we really emphasize those studies and are willing to take calls for all of them. But we really focus in on like a couple of them if their enrollment window is tight. But yeah.
And you just like wake up. And
Yeah. Yeah. I mean,
roll
we
with it.
can walk, like if we talk through it and we're like, oh, this kid was just intubated like 3 hours ago and is on pressors and for the foreseeable future will be, I'm like, I will take care of that at 8 a.m. But if it's a PISCAP kid where their enrollment window ends before work starts, then yep, it's a go.
Josie has a question in the back.
Is it working? Okay. So more just like a follow-up, like there's so many like different like varying sizes of institutions and teams. So I guess it's so dependent upon how it works for your team. But like I think one way that the notification has been successful from our team is that we actually have a group email. It's like critical care research coordinators at nationwidechildren's.org. And like that's the sort of like common communication piece that we like, anything that we send out, flyers that we put out in the PICU to notify us, it's always critical care research coordinator, critical care. So it's like one name, one group, and then everybody gets it. And so that it does eliminate the like, nobody's texting us at 2 a.m. or 4 a.m. or whatever. hopefully you've got your phone on silent anyway, do not disturb. But it does eliminate sort of that. But then it also, like, if somebody's on vacation, you don't have a notification just going to one person. And so it does keep it centralized. Now, granted, if you have a team of 20 people at CHOP, you might not all want to be getting the same notification, like, so maybe it's broken up into a couple of different groups, and, maybe similar for, your site, if it's like one or two people, it's easy to know one or two people's names. But that's like another kind of like option for notifications that keeps it more like centralized, and I don't know. So
Hello. Oh, Shelby, I just had a question because when you talked about getting like Volt messages at like 2, 3, 4 in the morning, like, are you guys getting overtime for that? Or like, do you work 40 hours a week? And like, once you put in your 40, you're done? Because at Minnesota, we're not allowed to work more than 40 hours a week.
If there was my HR representative in the room, yes, I work 40 hours a week. It's also, so I'm an exempt employee, which means I'm salaried. So our hourly or like hours aren't capped necessarily. Yasi is non-exempt, so her hours are capped. So I do encourage the team to communicate with me after hours, just since that's who's going to be, I'll be doing those 1 a.m. things. If Yasi does, she gets overtime, absolutely. But I tend to skew it more towards me so that A, she has a break, and B, so that our team isn't angry about her amount of overtime. Yeah. Good for my mental health? Probably not. Good for our screening? Yes.
Okay. My question is for Debbie, but we also have diagnosed, I think it's called Backline now. We have our team room and we can turn on and off those notifications, and we don't take overnight stuff. We're a huge proponent of boundaries at Riley because I know what that, yes, snaps for boundaries, guys. Because I know full know what burnout is like. So, I mean, but like, go you, man. I'm so proud of you. So, Debbie, I have a question. Where do all of those papers live? Like your screening ones? Like after the study's over, do you get rid of them?
After the study is over. So like those, so my weekly Excel sheets, the ones that I actually handwrite on, those I shove in a little folder, and then like every month or so I shred them or put them in the to be shredded bin. The notebook that I have is currently, I don't usually bring it like here. I usually will just scan a blank page or two, and just to keep writing the new ones so that I'm not backtracking too much when I get back. But at the end of the fiscal year, or sometimes I guess this past time of the calendar year, then I take them all out of the notebook and they're in like a file folder for now. Which why I don't do that, I don't know. They could be disposed of easily. Again, I'm just kind of old school, and I'm a visual person. So for me to look at something, sometimes like, oh crap, did I remember to enter that kid? Did I do this? Did I track down the Near for Kids form? So it's just easier for me, particularly since, I'll look I have to look on the weekends and do all of that, but I don't have to go in for the Near for Kids form. So that's when I just put it in that notebook to say they were intubated at this date and time. And it's a reminder that on Monday morning to say, oh, go get that sheet, or, hey, this kid qualified, like all the inclusion, but might have had an exclusion, to remind myself to make sure that all the forms are filled on Monday. Because I might not, it takes me long enough to screen twice a day on a weekend. And my husband sometimes will be like, again, what are you doing now? I'm like, well, there was a kid this morning that might, and I got to look again, like say noon instead of, an evening. I just wanted to add when she talked about at nighttime. So I particularly ask that for like PI's cap and precise, if it's a kid overnight, that they contact the PI first, or at least maybe include the PI in the conversation. It should not just be coming to me, because again, my husband's kind of a light sleeper, and if he hears ding, ding, dings, he's going to be like, what? So a lot of times I might get up in the morning and be like, hey guys, I'm sorry, I didn't hear it. Did you do? Oh no, we were hoping you'd get back to us. And I'm like, I just can't do that sometimes. But I don't keep my volume on, or it's in the bathroom on the counter charging so that it's not right there for us to hear. But
I just really wanted to quickly add, I am a huge proponent for boundaries. That sounded more dramatic than I meant it to. And we also are kind of a unique unit, and this, like, our evening texts only happen like 3 or 4 times a year. Excuse me. So it's really not like a heavy burden. Yeah.
Well, and as I'm listening to all this and the pressure to enroll people and the pressure to get people in, but stay within your 40 hours, all this boundaries burnout, I think right now, Shelby and I were just talking about, man, we should give a whole workshop on burnout. It could be an entire day. One, we do not get paid as much as the doctors, and we do our darndest and we do the work that we can, and then we call it a day. Unlike our units, we are not 24/7, 365. Maybe CHOP is, but majority of us, like, there is a beginning and an end. And I think it's really helpful when, like, I just send an email to our providers saying, hey, we're getting ready for the respiratory season. Just as a reminder, our work hours are 8 to 4. Beyond that, there is some wiggle room. If we enroll somebody in Paradigm, but we're having a hard time getting access to the line and we need to stay late to process, like, we will try to figure out a plan and finish what we've started. But I think right now, Shelby and I were talking about the phenomena of, with PALISI and with Capcorn and with these other critical care networks, we have grown exponentially. The number of studies that we have at all of our sites have grown exponentially. When I started 6 years ago, we had 2 studies that were in sad shape. And at one point we were running up to like 35. So I think we've created a monster because we have incredible coordinators who work so hard and get the job done. However, protection from burnout so that you do not kind of tap out after 2 years, 5 years in this position. How do we sustain our coordinators? How do we make sure that we protect them, that we are paying what we need, that we have the option for overtime within NIH grants? I think this is a whole conversation for like next year's education day or next time's education day, because this is something that I think is so important, because we create this elite team of coordinators who know these studies inside and out and are incredible at recruiting for them and getting everybody in. But how do we sustain that so we're not hiring and onboarding over and over and teaching some of these hard studies? So it's something that I just want us to like think about and start bringing back to our institutions. Like, how do we keep this good thing going, and how do we incentivize coordinators to stay longer than the average 2-year stint?
Woo! Also, CHOP is not a 24/7 institution. We are Monday through Friday, 9 to 5, and on call on the weekends, and we get paid overtime for it. And anytime there's an ICECAP kid, the PI gets notified, and there's a group of 4 co-Is, and if they enroll, then great. And it's optional if one of our coordinator team members goes in to help support, and they get compensated for it. But it's not required, and we can say no. Okay, Josie, what you got?
There's a question online, somebody looking for advice on keeping track of patients that are staying in the PICU for a long period of time. Do you check on them daily? So if any of the, I don't know, panelists or anybody else has thoughts.
I kind of talked about this. Oh, sorry. No, we don't. I think with screening, it's really easy. I think with anything, with data screening, and we're all very type A personalities. You have to do what you can do within the allotted time that you have. Like we just talked about, we're 8 to 4, so we can't spend like 90 minutes of those time. Like, if you're the coordinator that's responsible for screening, enrolling, sampling, shipping data, like, you just don't have that amount of time to be able to screen all of those really old admits every day. So we don't. But generally, I would say like a lot of our studies are for those acute patients that are recently admitted to the PICU. And I think at that point, if they do end up qualifying, I think you're just going to have to cut your losses at that point. I mean, margin of error, it is what it is. That's my advice. But if anybody else wants to.
Sean, do you maybe want to talk about what we do?
Yeah, I think for these, we kind of, again, use those reports that we pull from Epic. If it is a patient who has been admitted for a while and they do come up on one of them, we will kind of rescreen and see why they came up on, for example, the vasopressor report, see if that starts to qualify them for a study. I know some of the kids in our PICU who are trach vent dependent are kind of on our follow list for a while. So if we kind of go in, we'll check their OSIs daily, and then if there's anything that we notice, we'll kind of go back and see what's going on, if anything changed. But I think with all of that, it's tough to check it every day, but having some reports that kind of can pull those red flags for you helps a lot.
And we can, our screening notebook's electronic, so you can control find them and look up their notes from last time they came up or when they were admitted. I think we had a question back here.
I just wanted to say that, like, other team members as well should be involved in the recruitment process, and it shouldn't only fall on the CRAs or the research coordinators. And I feel maybe at St. Jude, we do a good job at training other team members as well, because you're not always there and you're working on multiple studies. So they might also be able to do some stuff, and we make sure to always provide them with consent forms that we keep in the unit for different studies, and we try to train them on the protocols. So just so if you're busy or you're not available, or if it's after hours, someone can do it. It doesn't all fall on your shoulders. And one other thing is that also at St. Jude, we have monthly meetings where attendings present their research projects. And there's always this discussion whether we have the bandwidth to take on a new project or not. So no attending can straight up come to us as CRAs and be like, hey, I have this new project, we need to start it. So it's a departmental discussion, and based on the bandwidth, also we as CRAs can say like, hey, we don't have the bandwidth to take on a new project, or we think we'd be able to, or we can delay it a couple of months. And I feel this discussions are important because it shouldn't be taken for granted that you're there to do the job. So any extra study that we want to add should just be added. So that's just what I want to say.
Yeah, thanks. All right.
Of like a little tidbit on the long-term patients too, I guess. It does depend, I think, a little bit on the system that you have. I hate to keep going back to, do you have Cerner? Do you have Epic? But I do think that like it is different. I mean, if I had Cerner and was doing it all manually, probably not doing an in-depth screen on them every day. I would probably, I think your best bet, because it's a patient that's critical but stable. There's probably not a whole lot that's changing. I do think that it's worthwhile to, on a regular basis, if you can daily or every other day, to at least like, if you can do one thing, pull up the physician note, the attending note for the day. That's going to give you a summary of like, did something change that you need to look in depth further, or did something not change? And that can be like a very quick skim done because you know that they've been there for a while. But if you have something like a screening report, this would hopefully be a patient that, has been in your unit for a while, and you can see on the report what kinds of support that they've been on. And then hopefully that report would be able to flag something new. And I think that would be then, like I might not pull up their attending note every day if I was able to be flagged in other ways. So I think there are ways to, because these are the patients that we miss in screening most of the time. The patients that are like, they're in there for a while, they go to the floor a couple days and come back. And like, we don't realize in our screening that they were gone and then came back and then now have like another acute illness that they probably would qualify. Or like the patient that's been in your unit for a while and then suddenly went septic for some other reason or whatever. And that's just also like, we're human and it's like part of the job. I mean, like those are just, I think, the normal misses. But I think that there are like quick ways to get around that so that we can at least capture them when we can.
Maybe a system like Shelby's where you have the people reach out would be good for like new vasos or intubations.
I was gonna say we like kind of stratify those kiddos because it is time intensive to screen everyone every day, like especially those kind of, we lovingly call them our boulders, because they sit there. But we get the alerts for CRRT or ECMO. So if a massive like organ dysfunction occurs, we are aware of that for our long-term kiddos. We do tend to screen them for like our funded studies to ensure that we're not losing out on kiddos that qualify for those, or if we have like enrollment targets that we haven't met, we try to like ensure that those studies are being screened. Or like Yassi's Pop-O2 met their meds, and those medications can be put on for an hour and a half and then stopped. So it doesn't really make sense to screen all of those kiddos all the time. But there is like a section of kids who are, if they're on CRT or ECMO, then we make sure that they're being screened for their meds every day because that's a specialized group that qualifies for that study. So we kind of take it that way.
Just continuing with this, like different ideas for getting more eyes on the patients and utilizing more resources. If it's okay with Katrina, we would also send out some of like the little mini flyers we've created for staff-facing locations, so we don't need IRB approval. She has done a phenomenal job making them very eye-catching, and it's just the high-level inclusion-exclusion criteria of what we're looking for, and our photo and who to call with our cell phone number for who's kind of the main person to that study. We used to laminate them and put them in the bathroom for bathroom reading, but I can't tell you how many times kind of back in the day, two different nurses would stop when they saw me and said, "Oh, I think I have a kid for you." And I think some of our bedside nurses, especially right now, we're in the day and age where many of them want to continue education in NP programs where they're required to do research. So I've gotten a lot of questions myself to show them how exciting research can be or how they can help. I think it's been important to show them who we're looking for and kind of what's the ask. Like, if a kid has sepsis, let us know. If a kid has an arrest, let us know. It doesn't always work, and that's why we do screen every day. But I love the idea of incentivizing. With our fellows before, we had a sticker chart, and for one of them, they got a free night babysitting from me for their kiddos, and for the other, he wanted a 6-pack of beer. We made it work. Both were very, very valuable for what they needed at the time. And so I think utilizing those resources, the fellows who have to do research to graduate, a lot of the nursing students who have to do research to graduate for their NP program, they're excited to talk with you if you can like give them some insight as well. So make sure that you're tapping into those resources. One of the things that we're talking about doing too is going to nursing huddles and giving them kind of a recap of a study, what we're looking for. And the most recent ask is, what results did you find? Why have we been doing this for 5 years? Was it worth it? Did you find anything? So I think that is something that we should be doing at our institutions for our providers and fellows to kind of give them a recap of where we are, what we've been doing, what we've found, and where we're going. And I think that helps to get buy-in with the whole team of why we're here, why we keep asking for PK samples of 2 drops of blood. But I think it's important when they get excited and they hear how they are changing the game in medicine. Because many of us work at academic institutions, we could just say, you're doing this because you're doing this because you work at an academic institution. That's not going to win over people, but we're doing this because we are changing the lives of children, and you're here changing the here and now. We're looking forward to the future. And so I think the more we can talk it up and get people excited, the more help we will inevitably get in screening or hearing about patients or having people excited about the work that we're doing.
Great tip. Thanks, Lexi. And thanks for everyone for presenting the screening panel and asking questions. It was a fun discussion. I think in the interest of time, we'll move on to Jen Mazinski's transfusion mini med school.